So just then briefly, my name is Gabrielle Bunny. I am faculty here in the Stanford Emergency Department. I'm a physician. And really my background is more on the software side. So doing a lot more with artificial intelligence. I do a lot with model building and model integration. So integration of technology into workflows and doing it from a methodology perspective. And then have been working with STEPP for now past over 3 years now. So have been very involved with STEPP, know a lot about the companies that have come through. So yeah, that's a little bit about me. I'll pass it off to Helen real quick to introduce herself and we'll get chatting about you guys.
Yeah.
Hey guys, I'm Helen. I'm one of the emergency medicine physicians at Stanford. I'm part of the clinical operations team and I have an engineering background. I'm new to the STEP program, so I'm here to support you guys and see what we can do.
Yeah, thank you so much. So in the interest of time, we will keep our introductions brief. So I'm Dr. Adarsh. I'm a minimal access surgeon. I mainly practice minimal access surgery and recently robotic surgeries. I am based out of Bangalore, India, and I have been in practice for last 20 years. And I have had an entrepreneurial bug, and I have had 2 previous ventures in health tech. And I saw this clinical problem in my own practice, and I took up this idea 5 years back, and I have been working on it. And I had a call with you guys probably 2 years back when I still had an prototype with the device. And over the past 4 years, last year we have received our FDA clearance and also our patents granted. And here I am back again with you guys. Thank you so much for providing the time today. Thank you so much. Rachel.
Well,
yeah, Thomas. Yeah.
Be our director, Dr. Adarsh. Who's next?
Yeah. Please, Thomas, you can go ahead.
Okay, thank you. Well, to keep it brief, I'm a career-long sales and marketing guy in medical device space. I've been here in the Bay Area. I think I'm our only member that's here in the Bay Area. So I'm here in the Bay Area for the last 30 years with several different device startups, some in orthopedics, some in vascular catheters, and other surgical tools. Thank you.
Rachel.
Hi everyone, I'm Rachel. I'm based out in Boston, Massachusetts. My background is on the product commercial strategy side, being a leader across everything from early front-end innovation through product development and launch. Have launched now 7 products, have done a lot of the work also in scaling those products globally, and also started off in engineering, but switched more into that product-facing side.
Jeremy.
Yeah, hey guys, I'm Jeremy. I'm in Rochester, New York. I'll actually keep it brief. I'm an 18-year med device sales guy, and been based in Philly and then up here in upstate in Western New York for the last 17 years. So nice to meet you guys.
Yeah. So if you are fine, then I will share the deck and I will start a brief presentation. Yeah. Yeah. Thank you. Thank you again. I'm Dr. Adarsh. I'm founder of V Medical, and our vision is to provide on-demand bedside abdominal laparoscopy without the OR. So the problem we are solving is that the current abdominal diagnostic modalities are inadequate. The clinicians, whenever there is a problem in the abdomen, clinicians face challenges in the way that CT, MRI, ultrasound, the non-invasive tests are inconclusive 30% of the in 30% of the cases. For example, it's very difficult to identify extent of bowel ischemia in bowel perforations or peritoneal secondaries. So these are the things that CT, MRI cannot or PET scan cannot identify. So this leads to delays, misdiagnosis, and wrong diagnosis. So results in unnecessary mortality and morbidity for the patients. So on the other hand, patients face the burden of next line of investigations in the form of diagnostic laparoscopy or laparotomy, which is again a surgery which is painful, expensive, and requires hospitalization. A critical gap exists between inconclusive imaging and invasive surgery, costing time, money, lives, and especially when time is critical. So our first application is sepsis. Sepsis is number 1 cause of hospitalization in US. 11% of the sepsis are of unknown origin, and with sepsis, time is critical. 80% of the sepsis deaths could be prevented if treated on time. US approximately spends around $62 billion annually on sepsis cases, around 1.7 million sepsis cases per year, and 30% of these sepsis cases are because of abdominal problems, and 11% of these sepsis, the origin of the sepsis is not known. So here is an sepsis patient. Unexplained sepsis patients can be too sick to transport even after imaging. A case of patient has all the symptoms indicating sepsis, with all the investigations are indicating sepsis with multi-organ failure, and patients are intubated on ventilator, on dialysis, etc. The common question in ICU is whether there is a bowel perforation or is it dead, for example. Or even these patients are on ventilators, so they are on muscle relaxants. Though, so eliciting clinical signs in these patients is very difficult. So very difficult to get a definitive diagnosis in these patients, and these patients deteriorate quickly. So so quick diagnosis and treatment is of importance. Again, if we want to transport these patients to radiology, we have to disconnect all the tubes, and many of the studies have shown that the mortality of intra-hospital transport is up to 70%. Or even if we want to take them up for OR, usually the OR is busy and the wait times are up to 12 hours, and these patients are very sick. They can die on the table. So surgeons are reluctant to take up these patients for OR. So all these problems lead to high mortality and morbidity in these patients. To reduce mortality, this patient urgently needs yes or no answer if the abdominal sepsis is present, and where is the source, and does the patient require immediate laparotomy, or can it be managed conservatively? And many a times what happens is that we take up these patients for laparotomy, and studies have shown that 50% of these laparotomies are unnecessary or negative laparotomies. This leads to, again, morbidity for these patients, morbidity and mortality. The Society of Gastrointestinal Endoscopic Surgeons, SAGES, already indicates bedside laparoscopy for unexplained sepsis. However, a bedside laparoscopy means moving the entire OR to an ICU, which might be impractical in many institutes. So it is not commonly adopted procedure. So, however, we are introducing P-scope, world's first bedside laparoscope for critical care in ICU. With P-scope, there is no need for delays. On-demand visualization without the OR, single use with integrated camera, reusable video and display. So there is a video and the scope here. It can be stored on the bedside, deployed by a single surgeon under local anesthesia. It's low cost, designed for rule out diagnosis. So we give local anesthesia on the abdominal wall, a transversus abdominal plane block. So basically it's a simple block. Blunt the needle, first pop external oblique, second pop internal oblique, and we are in the transversus abdominal plane. If required, we can confirm the needle position in the transversus abdominal plane, and we install local anesthetic in the transversus abdominal plane. So we block the intercostal nerves. So we block that part of the abdominal wall. So usually we perform, this is the scope, it's completely disposable. It has an optical port, camera, light source, a balloon, and a screen to visualize inside. So we make a small nick. Usually we perform this at the palmas point, which is 2 finger breadths below the mid clavicular line, to avoid any midline structures like the great vessels, so that there is no injury to the blood vessels. And we introduce it just like a laparoscope. We go inside, and once we are inside, we pump some atmospheric air to make some space in the peritoneal cavity. Then we introduce the device inside, and we can have a look inside the abdominal cavity. So these are the intestines, and if required, it has an integrated biopsy forceps, which can be introduced and take a biopsy. It has a feature of for irrigation suction as well. So this is the complete device. It is disposable. It would come as a kit. So you just open it, and perform this procedure and discard the device. So it has an irrigation suction as well here, and release all the gas, take out the port, and the patient is completely awake because this is performed under a local block. However, if we are performing it in ICU, we can call in an anesthetist and give some, if the patient is already on a ventilator, he's probably sedated on, he's so we can give some anesthetics and perform it without any local as well. So it benefits all the stakeholders in the healthcare ecosystem. For patients, it decreases mortality risk, and various studies have shown that there is change in clinical management in 70% of the patients. It avoids unnecessary laparotomies in 50% of the patients, and it reduces mortality rate by 20%. So various studies have been already done wherein they brought in the laparoscope in an ICU and performed these copies. So there is sufficient evidence for this, and the evidence is compelling for this particular application. For clinicians, it improves patient care, familiar technology, rapid diagnosis on demand. For hospitals, it lowers cost of care and improves efficiency. So ICU especially, it has an important financial aspect in ICU. So for if we are performing these procedures in an ICU, the studies have shown that 50% of the surgeries can be avoided with this scope. So we are avoiding a laparotomy, so we are saving around 20K on these patients, and also with quick diagnosis, quick treatment, on an average, we can save around 3 days for ICU stays for these patients. So approximately it costs 10K for an per day ICU cost for an sepsis patient in ICU. So if we are saving around 30K, so altogether around 30 to 50K is the saving per patient with the device sold at $2,000. And we also fit in the existing reimbursement codes, instant savings under inpatient DRG codes. Hospital generates additional revenue with increased OR capacity. Again, our contract manufacturing is cost is around $200, and we sell these devices at $2,000 with a gross margin of 90%. So our initial beachhead market is sepsis, approximately 540K patients with a TAM of 1 billion, and 11% of sepsis are unknown origin. That makes the SAM of 340 million, and with a novel device with patent granted, we expect a market penetration of 40% with a SOM of $100 million. However, it has other additional applications in oncology for staging of abdominal cancers. These are the peritoneal secondaries which cannot be caught by CT, MRI, or PET scan. So it has a very important application in staging of abdominal cancers. It has a potential to become gold standard in staging of abdominal cancers, also bedside diagnosis with sepsis, liver biopsies, evaluation of pain of unknown origin. And again, one more application in acute care is patients with blunt trauma abdomen, especially liver or spleen lacerations. In these patients, an important decision has to be made whether these patients can be managed conservatively or they require immediate surgery. With current abdominal CTs, that decision is very difficult. So we can go inside, have a real look, and get to a definitive diagnosis in these patients. Again, blast injuries or again stab injuries, wherein you want to see the whether the abdominal wall is intact or is there a perforation of the intestine. Again, it's a life-saving application there as well. Some applications in women's health like endometriosis, ectopic pregnancy, and infertility. However, these applications need to be studied. Again, many miscellaneous and future applications in military and en route care. So these are the future applications, and this takes the total TAM, global TAM, to around $40 billion, and the US TAM to be around $4 billion. So again, we have received an FDA clearance. We have received a very broad clearance for our device. Our FDA clearance states diagnostic and therapeutic procedures for endoscopy within peritoneal cavity, including female reproductive organs, which is a very broad clearance. Basically, if we compare it to the clearance for a laparoscopy, we have deleted the word surgery. Other than that, we can perform most of the endoscopic procedures. Our patents have been granted in EU, India, and Australia already, pending in US, Japan, China, Russia, and Canada. So as of now, 2024, our end of 2024, we received our FDA clearance, patent grants, and this year we completed our mass challenge accelerator. We formed our leadership team, and we also developed a clinical advisory board. Now we are looking to secure pilots and first manufacturing products, and get some user feedback, and then get to market right now. So again, if you compare it to the competitor, P-scope doesn't require any transport. It can be performed in the bedside. Mostly the investigation that can be performed in bedside is ultrasound or an X-ray. Beyond that, we have to ship that patient. Deployment, interpretation by single clinician. A surgeon can walk in the middle of the night, and he can perform the procedure and take that decision. No need to call the entire OR, and no need to shift the patients there. Does not require general anesthesia. No use of contrast. Again, these patients are in sepsis, renal failure. So again, if we do a CT, that may not yield much. So here we do not need a contrast. No delays due to backlogs, and low cost. And more than that, I would like to also add that just keeping a drain in a sepsis patient can again lower the bacterial load, and we can stabilize the patient and take them up for the next day in the OR. Again, that itself can be life-saving in these patients. Again, it has one particular advantage over CT, MRI, is that we can differentiate between pus, blood, or ascitic fluid, and also we can quantify the amount of fluid by going and looking inside. So that's and also we can differentiate with bile whether there is a perforation. So this is one of the main differentiator that this device will have over other modalities of investigation. So you have met most of them. So we have gone through all the major top tier accelerators in US, including UMass M2D2, where Thomas was my mentor, and beyond that he continued to be on the team. I met Rachel at Mass Challenge Healthcare Accelerator. Again, we have Ashley. She comes from MD Anderson and Johnson & Johnson. And presently we have had around 4 rounds of meeting with MD Anderson for our oncology application, and there has been a great interest. And we have also spoken to Sages. Sages has again taken a great interest. They have referred us to their STEPP program, and surgeons, we have spoken to many of the surgeons, including Dr. Carla Plug. I met her at Sages last year, and she has shown keen interest. And we have developed a clinical advisory board and many business advisory board, and there has been a great interest from surgeons and acute care community across the world. Thank you so much.
Thank you very much for providing that overview to your product. So just a few questions. So this is operated by a surgeon, correct?
Initially, ideally, acute care surgeon would be an ideal person. But as we progress, at certain stage, even the intensivist should be able to perform these procedures in the future with some amount of training.
Yeah, I mean, it would require a decent amount of training since they don't do any sort of laparoscopy at this point, but it sounds like, so it needs a surgeon.
Yeah.
And then, and the idea, and so it really sounds like you're focused on the ICU. Is that correct? So it's the ICU patient that you're interested in. And when you say you're looking for partners, what kind of partnerships are you specifically looking for? Are you looking for like performing studies on sepsis? Are you looking for like what kind of particular like areas are you focused on?
Rachel, would you want to take that question, please?
Yeah. So I'd say first, The first question about the ICU, I mean, that's kind of where we're trying to target originally, because that's where there's a lot of clinical literature that already supports the use of bedside laparoscopy. But if you look at this in general, the initial intent is that it could be anywhere in the hospital, right? The patient presents into the ED, right? You don't know if they're really septic or if they're bleeding. You could potentially pop this in, right? Like we would talk about en route care. And then, and so even too, like right on the floor, we were talking with another cardiac surgeon, and he was telling us, hey, maybe, you know, post cardiac surgery, if you're worried about bowel ischemia, this could actually just be done on the floor rather than the ICU. So that's that question. And then for partnerships, I'd say for right now, yeah, what we are looking for is someone in terms of like a research partnership to help us get value evidence, right? And also kind of confirm, right? Like what is the impact of this on the hospital, right? A lot of these things we believe, right? And there's a lot of evidence already showing kind of using a laparoscopic tower, but we want that evidence with our product. And so, yeah, the goal I'd say would be sepsis to start, but I'd say we're open to other applications if, you know, Stanford had a burning interest in some other disease state.
What do you mean by value?
Like,
are
we
you
would want to look
are you
at,
looking at morbidity, mortality, or are you looking at financial value, or?
I'd say both. So on like one hand, we'd want to know, right, like, does this increase time to action, right? That's kind of our whole initial value prop, right? Is initially, right, instead of waiting for an OR, can you do time? And then, right, once you get that time, could we follow the patient through the next couple of days and say, yeah, this patient got discharged faster, so they reduced length of stay, or yes, this patient had decreased morbidity, or with these patients, right, we were able to get them to treatment faster, and therefore it could be extrapolated they had a lower mortality risk, or even like actually get that. But I think we're open to like staging it in order to collect the value. And then we would translate it more in financials. I'd say like, if you guys have that capability, we'd love that, right? To say, okay, like, you know, this reduction in ICU days saved our hospital $15,000 on average, right? Like that would be huge. But initially we'd love the value kind of from a patient clinician standpoint.
Yeah.
So it sounds like your value is defined around time.
Initially, yeah, value on time, and then impact to like morbidity, right? Because if someone has sepsis, right, like the statistic about 80% of them aren't treated in time.
Yeah. So I would like to add a point that most of this value has been already captured in studies. Apart from the financial values, the clinical value has been already captured in many of the studies. However, we want some these to be validated with our device. So when we go to other surgeons, they would want some evidence with our device. Initially, so we want to validate that particular question. So that's what would be the aim, and also get the financial validation done. So these are the other things, and also reimbursement validation. So these will be the initial questions that will be asked to us when we get to the market. So this is where we need help from you guys actually.
Can I just ask, so it seems like the local anesthesia is enough for the trocar insertion, but like the air insufflation is pretty uncomfortable. Is this something that you imagine like having another provider provide like procedural sedation for, or is it how do you imagine like patient comfort being into play for this?
No, there are other procedures which have been done with atmospheric air. So usually when we use a laparoscope, the pressure we use is very high. So when we want to do just an examination, we do not, if we want to do a surgery inside, we go to a pressure like 14 or 16 because we need lot of space and we need muscle relaxants in general anesthesia. But just to go inside and have a look, we do not need such a space. So we don't need to pressurize the abdomen under such a high pressure. However, if I can share one more slide, please. So there are studies. There is another procedure that is done called.
Yes, Adarsh, while you pull that up, I think that even brings up a good point in terms of like what we might want to look at from a research partnership is helping to get some of this, you know, data, right? Like I think Adarsh is going to show you again, there's studies out there that show using this lower pressure atmospheric air, right, does not cause patient comfort, but having data with our device that says, right, X% of patients did not feel anything or would be huge for us too.
Sorry.
While he's pulling up, do you guys currently have any partnerships?
In terms of partnership, we are speaking to MD Anderson, and we have also collaborated with Sages at this point. So other than that, there are some other discussions going on.
I see. Okay.
And then I think based on your use case, it seems to be more like from the ICU standpoint. From the emergency department, what is there? Like, do you view this as a procedure that's being performed in the ED? Like, how do you imagine this partnership to look like?
I'd say, I mean, some of what we've heard, I think the tricky part with sepsis is, right, like the patients come in from all different angles, right? So they might present to the ED, and therefore, right, this might be a procedure done in the ED. A lot of times, though, we've heard that by the time it gets like where it's very unexplained and they would use this product, it generally is the ICU when it's sepsis, right? But if it's something like hemorrhaging, right, that might be an application to use it in the emergency department. So far, we've been very focused on sepsis, thinking that was our initial beachhead market, but I'd say we're open to like exploring other trauma indications within the ED as well, just given some initial feedback.
Yeah. So
does that answer, I guess, what is your thought, Dr. Liu?
Yeah, no, I just was wondering like what kind of patients you were imagining this to be used in the emergency department versus like an ICU or setting.
Yeah. So just for your question for the atmospheric air, so it's a common procedure, preoperative progressive pneumoperitoneum. So here is a large hernia with domain loss. So you can see the abdominal domain is lost, the intestines have come out. So we introduce a tube into the peritoneum, and every day we push around 2 liters of air for a week or 10 days, and we inflate the abdomen so that the abdominal wall expands. Then we open up the abdomen and we keep a large mesh, and the abdomen is closed. So as such, the insufflation of air and patients do tolerate air under pressure in the abdomen, and these procedures have been performed. And there is another study of around 2,000 patients wherein they performed laparoscopy under local anesthesia using atmospheric air, and so there is sufficient evidence available that atmospheric air can be safely introduced into the abdomen, and patients do tolerate the pressure pretty well.
Fantastic. Great. So no, thank you very much. It was a wonderful presentation, and really, I think, provided us a good sense of what the product is. And I'm really excited to see the progress that you've made. Because I wasn't a part of the original conversations, but I was taking a look, and the fact that you've gotten your FDA approval is fantastic. At this stage, we're at the half hour, and I think, and I do need to go to another meeting. But I really appreciate you taking the time to walk through your product with us. We're going to go ahead and we will take this back to our STEPP group, and then we'll let you know about next steps from there.
Okay, thank you so much.
Okay,
perfect.
All right,
Thanks all.
all right, bye-bye.
Thank you, guys.
Nice to meet you.
See ya.
Bye.
Bye-bye.